Next, I'd like to turn to my close friend, Dr. Robert Superko, not returning to LA perhaps, but returning to California, where Dr. Superko, as everyone knows, has become a leader in the assessment of biomarkers and genetics, and he will talk to us this morning about what is the role of biomarkers and genomics in prevention. He's the Chief of Medical Affairs for Celera, an adjunct professor at Mercer University School of Pharmacologic Sciences. Robert, as was mentioned earlier, we've all learned a lot about you in biomarkers, and it's a pleasure to have you here.
Thanks. Thank you. Well, that was very kind. Thank you. I've really enjoyed this session this morning. I like all the enthusiasm and critical points that we can discuss. So I have about 20 minutes here, and it's going to address this topic and integrate it with non-invasive imaging. So in terms of my disclosures, I'm the Chief Medical Officer of a company called Celera. If you remember the race between Francis Collins and a crazy guy named Craig Ventnor to decode the human genome, that's the company, 2001 Science Magazine. So it's basically a gene research company. Still involved in some clinical things. I have no other relationships with drug companies or industry or anything like that. So these are the topics that I'd like to hit in the next 20 minutes. Can we use genetics and biomarkers to improve a current risk classification? You've heard a lot about that with CAC score. Can we improve on the appropriate use of non-invasive imaging? And this is where I think we should integrate these concepts. Can we use this to improve on the classification of high-risk groups? And I'll talk about firefighters in that regard. Finally, does this have a role to play in invasive imaging? And I'll show you some new stuff on that. And then, of course, family members. So we've heard a lot about how terrible the Framingham risk score is. This is one of my favorite slides, simply looking at individuals with coronary disease in the solid ovoid and those without coronary disease in the dotted ovoid. The x-axis is total cholesterol, the y-axis is HDL cholesterol. So the solid ovoid, the dot in the middle there, is clearly to the right, a little bit higher cholesterol, a little bit lower HDL. So on average, people with coronary disease have slightly higher LDLs, slightly lower HDLs. But what's intrigued me about this for so many years is this tremendous overlap. So in point of fact, unless you're at the extremes, the use of classic risk markers to identify individual risk is rather difficult and fraught with all kinds of errors. So I think we all know this, we all accept this now. This is a recent study that you saw one slide on earlier, but the point I'd like to make from it is that you heard that this is get with guidelines. As people come in with coronary disease, about 75% of them have LDLs below 130, but almost 25% have LDLs under 70. So again, supporting the issue that just paying attention to lipids is going to miss the boat. Now, an interesting caveat, I was trial director of the first study to ever show cholesterol-lowering works up at Stanford. And do older people in the audience remember what that study was? Yeah, I'm dating myself. This was the LRC-CPPT, Lipid Research Clinic's Coronary Primary Prevention Trial. Big, huge NIH study. It got the entire cholesterol field going. And this is like maybe 35 years ago. And when we designed that study at the NIH, we knew at the time that cholesterol was not the most common cause of heart disease, but we needed a disorder that we could identify. We have a cholesterol test, and we needed a drug to treat it. We had cholestyramine. So in point of fact, when we did that first study, we knew cholesterol was not the most common cause of heart disease. When we published the study in JAMA in '86, if you'll remember, it was statistically significant by a one-tailed t-test, not by a two-tailed t-test. But we squeezed it through the JAMA reviewers because we said, well, we know that cholesterol is bad, and if you're lower cholesterol, it must be good, therefore we can use a one-tailed t-test. That's how the entire cholesterol field got going. Then the statins came along. There were a lot of studies showing that lowering cholesterol works. So it all revolved around this concept, but has now been morphed into the issue of lowering cholesterol and everybody must be good. Just remember your history so you're not destined to repeat it. So also in terms of non-invasive imaging, you're familiar with this, showing that individuals who are asymptomatic, about 63% of them had a low Framingham risk score. Of those 63%, almost 70% had some evidence of non-invasive imaging. So again, supporting the fact that standard risk factor classification is poor. So American Heart has come out with a statement just recently saying that we think physicians should get a bit more sophisticated. And we strongly advocate that physicians and centers, like you have here, develop an expertise in cardiovascular medicine so they can provide guidance to the community, both the public community and the medical community, and particularly in regards to which tests are useful, how to use them in which conditions, and perhaps use them in families. So you heard about the Family Heart Screening Clinic that uses coronary calcium screening, and the integration of these things makes an eminent sense. And of course, reimbursement is important. In my new job that I've had for a couple years, I've met with all the major insurance companies arguing for the reimbursement for tests based on studies and randomized clinical trials and things. And they're all very nice, but they all come down and say, well, great, the science is terrific, you understand the pathophysiology, you have tons of clinical trials. Boy, Robert, we'd love to pay for this test, but the last thing we need is a consensus conference. If there's a consensus conference, we'll pay for it. So they're all hiding behind consensus conferences, which by definition are 10 to 20 years out of date. So in terms of using these things, one has to consider the necessity for reimbursement and the cost. And of course, coronary artery calcium scores dropping from $400 a test to $100 a test has made a dramatic difference in how we use it clinically, and I'll mention that in a second. So we've talked this morning about risk determination, and that's sort of where my field is. Biomarkers, genetic tests. Can I give you a mathematical probability that you might have an event over the next few years? Well, that's sort of interesting, but what I really want is I want to do disease detection. I want to take you to the cath lab, stick a catheter in there, do an angiogram, and say, hop, see, there's the disease. So can we do that non-invasively? And that's where, of course, calcium scoring and all the stuff you've heard about today comes into play. So we can detect the disease, but once we've detected the disease, we should not just say, oh, good, we know they have disease, put them all on a statin. Because now the next duty we have as physicians and nurses is to determine the etiology of the disease. And clearly it's not cholesterol in all of our patients. So it's other issues, and that's where the biomarkers and some of the genetic tests come in to determine a personalized treatment plan based on the discovery that you know your patient has coronary disease based on an imaging test or carotid disease. So for example, at the bottom there, fibrinogen might not be a useful tool in the wide population and population screening, but it's very useful to diagnose a classic condition called hyperfibrinogenemia, which is a genetic condition. So again, you can't say, oh, well, because it's only in 1% of the population, we're going to test for it in everybody. But in some people, tests like this can be very useful because they have the disorder. And then the thought is, as you heard, well, we're going to do this study, put them on 40 of atorva, 80 of atorva. But we've published, going back to 1996, where we actually had an article called Beyond LDL Cholesterol, which got us into a lot of trouble with the drug companies because the point of it was the use of cholesterol-lowering therapies has failed. And so this is from that paper, and there was an updated one in 2008 in Circ. And what you're looking at are clinical trials, and the height of the black bar is the percent of people having a cardiovascular event in the placebo group. The height of the hatch mark bar is the percent of people having a cardiovascular event in the drug-treated group. So it's the difference in the heights of those bars that's the 25% relative risk. There's a huge number of people taking the drugs, lowering their cholesterol, and still having an event. So while lowering cholesterol is important and gives you a relative risk reduction of 25%, it gives you an absolute risk reduction of about 3%. So if we've made the diagnosis and now we're going to treat our patients, it behooves us to be very specific about what that right treatment is for that individual. So treat the disease, not just a laboratory number. Just don't go after an LDL and try to get it down to 129, but 131 is bad. Find out what the metabolic or genetic disorder is and treat appropriately. So again, we've had statements from American Heart and other organizations saying, okay, fine, you have these advanced tests. How can we use them? Well, we should use them if they help us reclassify a patient so that we do something different clinically. And you've heard about how CAC scores does reclassification. Well, these tests can do something quite similar. So the next topic is exactly that. Can we improve on the use of non-invasive imaging? So there was a previous slide that was similar to this too, simply indicating the fact that still, according to American Heart, 50% of people find out they have heart disease when they suddenly drop dead. And one approach to that might be, say, well, let's go out and do a CAC score in everybody in the population at a certain age. The other approach might be, maybe we should use some kind of test to identify accurately higher risk groups and do the CAC scores in that subgroup. And that's what I'd like to address now. The concept of using a genetic risk marker to identify individuals who will be enriched in positive CAC scores, and therefore that might be a reasonable clinical thing to do. And the example I'd like to use is something that was discovered simultaneously and published by both Bob Roberts and his group at Ottawa and the DECODE group, and it's called 9p21. It's a polymorphism on chromosome 9 on the short or petite arm at position 21 or 21.3. So it's called 9p21. And when they found this through a GWAS study, it was this huge Empire State Building on the Manhattan plot, and they said, oh my goodness, what the heck is this thing? It appears to predict early onset MI very powerfully. It predicts standard MI, and it predicts AAA. However, it's in the junk region of the DNA. We don't know what it does. And I'll show you what's going on right now. But then a whole series of large GWAS studies were done, which are shown here. And it turns out that having this marker, this specific marker, which is quite prevalent, 25% of the people in the room are homozygotes, 50% of you are heterozygotes, and I'll come back to that in a second. It's totally independent of all other risk factors, and it's as powerful as cigarette smoking, and the p-value for its mathematical or statistical significance has 60 zeros after it. So being a clinical trialist for most of my career and looking for a p-value of 0.05, this just knocked my socks off. Well, remember, in big GWAS studies, you need a p of 10 to the minus 8th to be considered acceptable, but this is 10 to the minus 60, for God's sakes. So does this mean that you should all run out and measure it tomorrow because it's statistically significant? Well, no. It has to have a clinical relevance. What this tells you is this is not happening due to chance. This is real. This is something you shouldn't ignore, but how you use it clinically is the trick. So how important is it? Well, here's classic risk factors: age by 5 years, current cigarette smoking, LDL and HDL by 1 standard deviation changes. And over on the right is the heterozygote risk in yellow and homozygote risk in red. So one could arguably say that having this knowledge is as important as classic risk factors and as important as cigarette smoking. So bingo, that's one piece of information. If my job is to categorize your risk, if this is totally independent of everything and tells me whether or not you're at the same risk as a cigarette smoker, then perhaps it's relevant. So how might you use it? You've seen things similar like this. So in a low-risk group, if you do something that increases their risk a little bit, they're still going to be low risk, and that doesn't help you very much. If you're high risk, you know you're high risk already, you're going to treat it, and if I say you're even higher risk, that doesn't help me very much. It's the group in the middle, the intermediate risk. And so one reason we made this slide was to say, well, if you can recategorize to a higher risk, then I would use more medicines or add niacin or do something different. One thing you consider might be non-invasive imaging. So if I'm going to tell you I want you to go on lifelong drug therapy or go to Arthur Agatson's website and sign up for the South Beach diet at $30 a month, maybe I only want to do that if you're really at higher risk. So if this cranks you up into a higher risk category, clinically, that might make me do something different. So indeed, this has been shown by a clever guy named Bratbauer in Texas using 9p21 in the Framingham risk score and identical stuff, almost identical stuff with ERIC risk score. And the way to interpret this is across the top is the Framingham risk, 0 to 5, 5 to 10, 10 to 20. Going up and down on the y-axis is the exact same thing. And then he said, if I add the information I derive from 9p21, how many people would I reclassify to a higher or lower risk category? So that 97.7 in the upper left-hand corner indicates that 97 or 98% of the patients would still be low risk if you identified 9p21. Off to the right near the bottom where it says 87.7, that means that about 88% of individuals would still be high risk if I did 9p21. But it's the group in the middle where you reclassify about 25% of people to a higher or lower risk category using this very simple test. So the second thing here is a very simple thing to say I'm going to add another parameter to my risk classification, and if your risk changes, then I'm going to do something different. If you're not going to do anything different, then don't even think about doing this, of course. But if it makes you consider doing something different, it can be useful. So one of those different things might be, I want you to spend $100 and go to Dan's place and get a CAC score. And so there is a statistical relationship between this 9p21 polymorphism in Caucasians and coronary calcium. Now, one of the really interesting things about genetics is ethnic differences. So whenever somebody gives you a lecture on genetics, you have to say, well, what's the difference in African Americans or Caucasians or Indians and that sort of thing, and that's very true. One of the problems, even with the studies we've done, is the number of Caucasians is huge. The number of different ethnic groups is smaller. So nevertheless, at least in Caucasians, there's a relationship with this very simple polymorphism and coronary calcium. So Bob Roberts has come out with this concept that we need a totally new paradigm, and that paradigm might be the use of genetic screening, particularly in people with a family history of heart disease, because if we're going to attack this disease, we need to attack it early in life. The second or third decades, 20 or 30 years old in men, perhaps maybe a little bit later in women or the same age in women. But if you're going to make a decision about lifestyle change or particularly lifelong drug therapy, perhaps it should be based on some additional science, such as genetic testing. So the next topic is, can we improve classification in high-risk groups? And the example I'm going to use for this is firefighters. So Brenda and I did a study 5-6 years ago now in Atlanta in firefighters because the fire chief was complaining in Atlanta that all his firefighters were dropping dead from heart attacks, not dying in the fires. So we did some research, and it turns out that studies initially done in Toronto and other places indicate that firefighters have 300% more heart disease than other professionals, and nobody knows why. So we did this study, got your tax dollars, thank you very much, did a big study in firefighters, published it, showed a whole bunch of the reasons, did 1 million SNPs and that kind of stuff. But the important thing for this group is these were healthy, active firefighters out there fighting fires. A third of them had coronary calcification they didn't know. So at the end of this study, we appropriately sent them in the right direction, and we thought, well, we have some moral imperative here. We need to do something more than just this federal study and go back to the lab. We need to screen all the firefighters in the United States. So we started a program in Atlanta, and we said, first we need to screen the entire Atlanta Fire Department. And we went to a company that does lab tests and said, you got to sell us those lab tests at a really low price because the firefighters want to pay cash. They don't want their insurance to pay for it or the county to pay for it because they don't want the fire chief to know the results. So they want to pay cash, but they don't have much money, okay? And these are the greatest guys and gals in the world. So we got some very low-cost tests. We went to the hospital. And said, we want some nurses and doctors to volunteer. A bunch of people said, yep, we'll do that. We went to the hospital and said, you have to give us that CAC score for free. They said, oh my God, we can't do that. We're charging $400 for it. We'll lose our shirt. And we said, no, no, no. Give us a chance. Try it. So we did it and did about 5,000 firefighters in the community on this volunteer-type basis. A third of them have coronary calcium that nobody knew about. And what happens to them? Oh, they go to the hospital. They say, oh, we need a stress nuke. Now we need some. Now the hospital's thrilled. So if you want to do this, consider that when you talk to your administrators. Is they have to do this for free. Give it to the firefighters, all the tests, everything for $90 or something, and you can identify a huge amount of disease in a very high-risk group. So that's my one political statement today. So how about improving the use of invasive imaging? Well, again, using the 9p21 example, up to this point, we had thought that, gee, this thing is useful in primary prevention to reclassify risk. That makes a lot of sense. The science has advanced tremendously. Bob's presenting some data here at American Heart, but the etiology has to do with ANRELs, non-coding regions of DNA that actually regulate other gene expressions, which has to do with the inflammatory pathway, particularly alpha interferon 21. So this actually opens up, as you saw earlier, a whole new process of why atherosclerosis is occurring. There's all kinds of other mechanisms, just not the cholesterol mechanism. This is one huge mechanism. And now he's looked at coronary arteriograms. And there's a powerful relationship between gene dose and arteriographic severity. Not only gene dose, but left main disease, the need for early bypass surgery, and the severity of the disease by Gensini scores and other ways to look at it. So there might be a role to play in secondary prevention. And in this study, looking at early onset coronary disease, or MI, and the 9p21 polymorphism, there's another gene dose effect in the need for revascularization. So when we do invasive procedures, of course, one of the big concerns is when are they going to come back? And a good cardiologist will say, okay, I'll take an aggressive approach in preventing your reoccurrence. Nevertheless, it happens. And it turns out that this has a very powerful role in predicting the need to come back for a reintervention, independent of every single risk factor they can throw at it. So the final comment had to do with high-risk family members. And you heard about the Family Heart Disease Clinic here. This is something that Brenda and I have been doing for about a decade now. And we have a paper that actually came out of SHAPE 2, and you see Bob Roberts there and Spencer King and other people, and it argued for the use of both genetic and inherited biomarker testing along with non-invasive imaging combined into a family heart disease prevention clinic. And when we did this in Atlanta, one of the most gratifying things was to have a patient come in with disease, premature disease or coronary disease, discover why they have it, then bring in all their first-degree relatives, measure the same thing in the first-degree relatives, and find the family members that are truly at high risk, who you then might want to process on to other kinds of imaging or invasive diagnostic techniques. So it's something to very powerfully consider. So entire families sometimes show this tendency to early arteriolosclerosis, a tendency which cannot be explained in any other way than in the makeup of the machine, bad material was used for the tubing. And again, this was the brilliance of Sir William Osler back in 1892, suggesting that we have family heart disease clinics. And Carl Berg, who discovered Lp(a) and other things back in 1989, said, well, it's time we get off our duff and do something, particularly having a family-oriented prevention clinic focused around genetics. And it can be genetic simply by family history, but remember, when you hear family history in these studies, very often obtaining the family history was not done very well. It takes time and a fair degree of intensity to do a good family history. Also, people die from automobile accidents and things as well. So the family history you hear about in these clinical trials is not the family history that you take in these family history clinics. It's much more specific. So what's changed this radically is the cheek swab. So when we did this in Atlanta and we had a patient with 9p21, let's say, and we said, okay, we want to get your Aunt Jane. She lives in Alaska. So we'd have to get Aunt Jane to go to a laboratory and get her blood drawn, and then the blood mailed, and how do you mail it? And they don't know how to draw it or pack it, and it was very, very difficult. However, now you can do every single gene test you want on a cheek swab. So we just send an envelope to Aunt Jane in Alaska. She swabs her cheek, sticks it in the envelope, mails it back, bingo. We got just about anything you want to measure genetically on it. So think about this with your families, because all the families are not here. They might be in New York or New Jersey or swimming around back there someplace. But you can actually do this very easily now with these buccal swabs. And this was a paper we had, again, with Bob Roberts, calling for this specifically to develop these family heart disease clinics. So if you want a big win right away, think about establishing something like this. Be enriched with coronary patients, the families love you, and if you get a bunch of rich people, like you have here in LA, you might get a lot of donations. You can cut that off the tape if you want. So here's one of our families. The father had an MI at 57. He's 9p21 positive, so is the mother. So their risk of having a premature event is increased by about 50%. So that's what the data shows in these big studies, a 1.5 increase. However, they have some children, and the one child there is a homozygote. And that homozygote has the same increased risk as being a cigarette smoker. He has a twofold increased risk. He's 35. What do you do with a 35-year-old that now has really high risk? Well, would you do a coronary calcium score? Well, maybe. 35, I'd use that in my equation. I'd kind of figure out what I want to do individually. Would you use a statin? Would you use statin and niacin? Would you give them fish oil? So you have to think about all this yourself as the clinician. However, this approach identifies that individual that you want to focus a lot more attention on compared to other people like his brother over here who doesn't have this very significant risk factor identified by a simple genetic marker. So in summary, I believe that genetic and biomarker tests should be integrated with non-invasive imaging, as you've heard about today. It improves the patient risk classification. There's no argument about that. You want to identify the most productive group for non-invasive imaging. So one argument would be, okay, let's go out and do 9p21 in everybody in the population, and those that are homozygote, let's do a calcium score in. Or you could say, no, let's do calcium scores in everybody in the population. If it's positive, then let's do 9p21 to see if that's, or some other genetic test to see if that's the etiology. So you can figure out what you want to do, or a combination of the two, which might be the most reasonable. It improves identification of high-risk subjects. Obviously, as I showed you by this one example, there are a number of others. It can improve the effective use of imaging, invasive imaging. So in your chronic coronary patients, or you're thinking about doing some kind of invasive technique, but they're on the sideline, if you had a test that tells you the likelihood of having severe arteriographically documented disease is higher, would they be of any use for you? And it's very important, of course, for family members. So my recommendation is to organize, complete, and publish a consensus conference, because that's what the insurance companies want, that would convey expert opinion and impact reimbursement on this issue. And the issue would be the combination of non-invasive imaging with genetic and biomarker tests to do the best job we can for our patients. Thank you very much.